A very good evening to all of you. On behalf of Chest Council of India, I welcome you to today's webinar. Today's webinar, like our string of academic endeavors at CCI, again entails a topic which I feel is very interesting. Although we have been repeatedly at it over the past 1.5 years, but still it becomes an enigma when actually a COVID positive patient now shows up who is mild in severity. What is the role of this amazing new thing that we keep on hearing about repeatedly, which is the antibody cocktail? Today, we have a very interesting lineup of panelists with us at CCA, who are all our life members. The moderation will be done by Dr. Raja Dhar, sir. I am just keeping place for him in view of the very heavy traffic in the city of Joy. Dr. Raja Dhar, sir, as we all know, is a teacher recently awarded with the Dronacharya Award, dear to us all. He's also the director and head of pulmonology at CMRI Hospital, Kolkata. Adorning our galaxy of speakers today is one more very respected member of the Chest Council of India family, Dr. KS Satish, sir. Sir is one of the first fellows of CCI, and he is a consultant pulmonologist attached to Fortis Hospital, Bangalore, Vikram Hospital, Bangalore, and sir is an excellent golfer.
Thank you.
Now, coming to our other panelist, Dr. Keerat Sibia, Center Ludhiana. Welcome, Keerat Sibia, on the board. I would like to welcome Dr. Vikas Pilania, sir, who is a consultant in pulmonology, critical care, and sleep medicine at Manipal Hospital, Jaipur. Welcome, sir. It's been a long time. We wanted to have you on one of our panels, and a great day to be with you today. Then, last but not the least, our boy wonder, Dr. B Viswesvaran. Not a lot of introduction for CCI followers for Dr. Viswesvaran is needed, but still, he is MD DNB DM and he is consultant interventional pulmonologist at Yashoda Hospital, Malakpet, Hyderabad. Again, if anybody is his Facebook follower, you will also be his fan. Great going, and welcome Viswesvaran on the board. And I have the opportunity today to introduce myself. I am Dr. Ravi Dosi. I am National Secretary, Chest Council of India. I am Professor and Head Department of Pulmonology at Sri Anandendra Institute of Medical College at Indore, Madhya Pradesh. So, without taking too much of our time, I would like to open today's very interesting seminar on this management of mild COVID-19 with two very interesting cases. The first case will be presented by Dr. Viswesvaran.
Thank you, Raja Dhar, sir, for the introduction. So, myself, Dr. Viswesvaran. So, today I will be discussing with you about a case of a mild COVID-19 who presented to us. And after that, we'll be having some question and answers on the same case. So, the patient was a 70-year-old male and he was a resident of Hyderabad. He was a known case of diabetes and a hypertensive patient, and he was chronic kidney disease on hemodialysis. He had a history of travel to the outstation 1 week back, and right now he presented with complaints of fever for 4 days, dry cough for 3 days, generalized weakness, but there was no history of any breathlessness or chest pain or hemopsis. On examination, the patient was found to be conscious and oriented. The saturation was 98% on room air. The pulse rate was 88 per minute, respiratory rate was 22 per minute, and the blood pressure was 160/90 millimeters of mercury. So the patient was evaluated outside and was then referred to us for pulmonary consultation with the following reports. The investigation-wise, his hemoglobin was normal, his TLC counts were normal, and platelets were within normal limits. He was a CKD patient and his creatinine levels were higher, which was at 6 milligram per deciliter. And ECG was suggestive of left ventricular hypertrophy secondary to hypertensive heart disease. And liver functions were normal. CRP and D-dimer, which was done outside, was within normal limits, and HbA1c was 8.4, suggestive of uncontrolled diabetes. and COVID RT-PCR done outside was positive and H1N1 was negative. The CT he was carrying with him prior to presentation, which was relatively normal, and there were no features to suggest any pneumonitis. So the patient was then treated in an outside clinic with tablet doxycycline, ivermectin, tablet Zincovit, and Limc. And upon evaluation at our center, we found this patient to have the high risk criteria for getting the monoclonal antibody. The patient was more than 65 years of age. He had underlying diabetes, hypertension, and a CKD. So we initiated this patient on injection casirivimab 600 milligram and injection imdevimab 600 milligram as a stat dose. Following which the patient had relief of symptoms and the fever differed within 2 days of initiation of monoclonal antibody, and the patient continued to remain asymptomatic at 10 days of follow-up. So I'll end my case here, and we'll take up question and answers related to the case and further proceedings. Thank you.
A very good evening, everyone. I'm Dr. Keerat Sibia, and I'm very happy to be here with our CCI family, our esteemed panelists, and Dronacharya, Dr. Raja Dhar. I will be walking all of us through the second case for today's evening. A 53-year-old gentleman books an online consultation with you after testing positive for COVID on RT-PCR. He stays in the same city but is wary of the COVID scenario and thought he'll visit you only if required. He complains of fever up to 101 degree Fahrenheit since the past 2 days with body aches. He also complains of sore throat, which he says is now settling. He got CT done from the friendly neighborhood radiology center, which he shares. CT severity is 5 out of 25. He further informs that he has been using CPAP since past 3 years for OSA. His BMI is 28. He is a controlled hypertensive with no other comorbidity. On inquiring further, he tells about his vaccination status, that he has received first dose of Covishield and is due for his second dose in about 20 days' time. His fever is otherwise responding to PCM, and he is requiring to take PCM about once a day only. There's no history of cough, breathlessness, or syncope. So how would you like to approach this case? Would you advise him to visit your facility or review him with online consultation? Do you think he is at increased risk for disease worsening? Can he potentially benefit from antibody cocktail? Is he even eligible candidate for antibody therapy? Would you like to advise COVID antibody titers in this patient? Or would you maybe consider convalescent plasma therapy? What kind of antibody titers would you want assessed? And how do you plan to evaluate the antibody titers? Are there any validated endpoint antibody titers? How would you choose the appropriate monoclonal antibody therapy? Would knowing the SARS-CoV-2 variant strain influence your choice for monoclonal antibody? Can you give COVID antibody therapy using single monoclonal antibody agent? And finally, what further challenges would you anticipate with this case and antibody therapy? Let's get started then. Thank you very much.
Relatively common case scenarios that we come across, a lot of questions that Dr. Keerat put up at the end of your case, whether to do this, whether to do that, Then there is this whole thing about lot of thing about cocktail coming in, and then you are confused whether the patient is vaccinated once or twice. So I would like to open our panel discussion today with Dr. Satish sir. I would say, like Satish sir, in this situation of a mild COVID pneumonia in the pre-antibody cocktail era, uh, how would we have gone about? What would you think would be a good choice for this patient?
Okay. Um, Thank you so much, and for the CCI for having given me an opportunity, and nice to be here on this platform. Raja is back. Welcome, Raja.
Welcome.
Okay. So in the Ravi, in the pre cocktail antibody era, which means the early second wave or probably the first wave, we were all trying our best to give medications which were known to have some effect without any proof, without any medical evidence. There were trials which were going on, especially in the first wave. All of us tried various combination of drugs and so on. But everything changed, I think, in the second wave when we had a lot of trials, the recovery trial and various other trials which came to our help and saying some of the medication that all of us were using were useless or were harming patients. And for example, what would I do for a patient? What did I do for a patient during that time before the COVID cocktail antibody was available? Was to give, supposed to have some, if it is a patient who has mild and stayed at home, didn't come to the hospital, I was giving favipiravir in the first wave. And that all changed anyway in the second wave completely. I've never used this after that. And so they were the only drug, I think, which was some evidence. And I have used in some patients, Ravi, drugs like ivermectin, very initially, doxycycline maybe, and never used azithromycin in the first wave or in the second wave. So I was doing all that, what was being done all over India by all of us, trying to discover this virus, learn about this virus, and waiting for some of the big trials, landmark trials which were going on. Once the trials came up, forget about the antibody, COVID antibody, cocktail antibody, many other drugs were out of my dictionary. I took off all of them, and I was very confident in the second wave not to give any medication for mild COVID, nothing at all. Never gave any medicine except budesonide inhaler and supportive care and warning them about various red alerts and to get back to us if there is any problem, and taking hydration, taking care of their health and other comorbidities which they had. Apart from that, nothing I did in the second wave. Became more confident as the trials unfolded in front of me. Thanks.
So I welcome our original moderator of the day. Welcome, Dr. Raja Dhar sir.
Thank you very much, Ravi. You are always the original moderator, so I'll just take over from you. Thank you to CCI for organizing this. And hello to yourself, Satish, Keerat, Vikas, Viswesh. So hi to everyone. Lovely to see all of you. Ravi, have we done the cases? Have the cases?
Yes, sir. Both our cases have been presented brilliantly by our two people. We are on our. I just begin with. I thought before you join in, I'll be talking about the prehistoric era of pre-antibody cocktail.
Right. Okay. Grand. And I can see questions coming in, which is great. So I know we'll have a large audience. So please put in your questions. We'll try and take as many of them as possible, and we'll do them during the course of the discussion. So same question again. I'll take what Ravi said forward. I'll come to you, Vikas. Vikas, you agree with what Satish has done for the first and second wave? And I'll quickly put this question to others. So if you agree, we'll just go to someone else. But if you don't, what is different? So no antibody cocktail at your disposal. how would you have treated these patients during the first and second wave? Vikas, you're on mute.
Definitely, sir. As Dr. Satish said, we don't have any agent with us before this antibody cocktail, which have proven efficacy in mild COVID cases. So we have to use the agents. That agents have hypothetical efficacy in the COVID era. And frankly speaking, most of our patients, even 90% of our patients, used to come with us with a prescription from some family physician and all, prescribing them ivermectin, favipiravir, doxycycline, azithromycin, vitamin C, zinc, blah, 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 blah. And we don't have left with
Vikas,
any choice.
Just hold on one moment, because that's your prescription, or this is a choice of drugs that were given? The entire list that you spoke about?
Sir, frankly speaking, physicians having a pre-printed prescription with them.
Right.
They just
So you used to tick. So what would you tick, and what would help you to decide which one to take and which one not to take?
We don't have any choice other than to say the patient, कि भैया ये continue कर लो and keep close watch on your symptoms and your oxygen saturation. If your symptoms are worsening or oxygen saturation dipping, come to us for further management, because we don't have the strong enough evidence to against these agents. And
तो विकास, मैं आपको थोड़ा सा और पुश करता हूँ. I'll push you a little further. आप मुझे ये बताओ कि आप लिखते क्या थे. सोचो आपके पास कोई पेशेंट नया आया है. So say I'll give you an artificial scenario. So there's someone who is 60, diabetic, who comes to you on day 3 of onset of fever with a little bit of a dry cough, no other comorbidities. ये patient आपके पास आया है, online consultation कर रहा है, akin to what Keerat said a little while ago in her case. तो आप इस patient को क्या prescribe करोगे in the pre-antibiotic era, in the pre-cocktail era, sir?
So same as I was saying, we don't have any choice to prescribe other than favipiravir, ivermectin, doxycycline, vitamin C and zinc.
Okay. So that's your prescription, standard prescription for anyone. That's fine, Vikas. That's fine. So Vishwesh, anything you would do differently? What's been your practice quickly? And then I'll come to Ravi. I know Ravi has got the largest number of patients. We'll ask Ravi last. Vishwesh.
So, the first and the second wave, except for monoclonal antibody, to be very honest, nothing has changed. And one thing what we observed was we never had good response to favipiravir, and initially the capsule burden was also very high. So we refrained ourselves from using it because the evidence was not very strong. But there were initial some case reports and case series which suggested a benefit of doxycycline and ivermectin based upon animal models. That is what, since we didn't have anything in our armatorium, we were forced to use it. Given the second wave, even now for the patients who are not at high risk, we still give doxycycline, though many studies have negated its role. There are few studies which still support there could be a potential role of a doxycycline. So we still give doxycycline. But any high-risk patient who fits into the ambit of cocktail therapy, we go ahead with, we try to convince them for an antibody cocktail. And at least I would say that in an experience, 60 to 70% after seeing the havoc of the second wave, they are...
Which will I come to the antibody cocktail. Most of our meeting will be on the antibody cocktail. So I'll quiz you about the antibody cocktail. I've got the gist of what you said. More of doxy and ivermectin, less of favipiravir and the vitamins. Keerat, anything different to add, or you agree with what's been said? Keerat, you're on mute.
So I agree with what Dr. Satish said and Dr. Vikas said and what Dr. Viswesvaran said. The fact is that we as pulmonologists, so Dr. Vikas said that when he receives the prescription of the family physicians, they have been prescribed some antibiotic, basically azithromycin or ivermectin. So very rarely you will see them prescribing favipiravir. So that was what the trend has been. So when favipiravir came about, it was the prescription of the pulmonologists, which when it went into circulation, was we were the premiers. We were actually pushing for this drug because it seemed that there was a more direct action and better response. It was reported. We did not find, our personal experiences might vary, but we have been the first to take up the newer drugs while others are still hanging on to the older drugs, repurposed medication. So, I agree. Favipiravir we were quite, I think we have been happy to use it. But yes, given that the antibody cocktail has come, I mean, I really look forward to discussing more about this, but a lot of scope has opened and we have to be very, very open about it. It's very important.
Sure. Ravi, come to you. Same question. Briefly, what have you done with your 3,500 odd patients or 10,000? I don't know the exact number, but there's a lot of patients with COVID. So tell us.
Sir, I'll be very humble and very clear in what I did. I made a pre-printed pro forma having ivermectin, Fabiflu, doxycycline, and all the drugs. Then if there were two patients, one who came with a prescription already taking, so whatever was left, I used to take that. And if there was a new patient, I used to take on all of them and give it to them together. This I did for first and second wave. Frankly speaking, a lot of them improved because they would have improved anyway. But the principle was simple: to help always and harm never. It was not harming anybody, so we kept on doing it. That's all.
So Ravi, I love that honesty. So I am on the same boat as you are, maybe slightly different in that. We'll come to this question. But so in the 1,000 odd mild patients that I have treated during the first two waves, I have actually prescribed some drug or the other. And I think drugs, prescribing medications which are reasonably harmless actually does something for the morale of the patient too. I think if you leave a patient saying there's no drug which is evidence-based, please go home, I think that probably does more damage to the patient's psyche rather than giving something to clutch on to. And I completely agree with Satish about the inhaled budesonide. So that's one area where my practice changed during the second wave. With the stoic results, I was actually very comfortable prescribing inhaled steroids to these patients early on in the disease onset. I think that's a great thing. We'll come to a little bit of discussion as to whether we can categorize patients into patients who go on to an antiviral, as in favipiravir, patients who might go on to doxy or ivermectin, patients on inhaled budesonide in a bit. So we'll do that in a little bit. But let's take the discussion forward with individual drugs. Let me come back to you, Ravi. I was going to ask you about vitamins and minerals and giving them to all patients with mild COVID. You just talked about the tick box exercise. So is that what you did? Ticked the zinc, the vitamin D, the vitamin C in all the patients? Or what's your thinking about vitamins and how would you place them in the third wave when it comes?
Well, as far as the experience in first and second wave was there, sir, I definitely used to take it in almost all of my patients who were able to eat anything. I wrote syrups for patients who didn't eat and drank. So but I prescribed vitamins to practically everybody. I prescribed them for a short period of time, but I ended up seeing that patients who had mild COVID came 1 month afterwards and they were still on vitamins. They used to stop everything else, but they used to continue with vitamins somehow. So I realized that they tend to have a lot of gastritis and nausea if they take it very prolongedly for more than 2-3 weeks. So I understood the shortcomings of giving vitamins without any indication. So in the third wave, definitely I would not prefer prescribing them to every person. Maybe if you pick up something or a patient with a tendency to have ulcers when he takes medicines, you might give him a vitamin or two, but not needed as such. And very frankly speaking, the problem is people have a tendency of associating vitamin therapy with a boosted immunity. So on that pretext, they keep on taking, and are taking it for months and years together.
Sure. Grand. So, fellow panelists, if you want to add anything to the question, just press on the raise hand icon or just raise your hand and I'll be very happy to take the question across to you. I can see Satish's hand. Is that for practice or is there a point that you may want to make, Satish?
I want to make a point. Just quickly, Raja, I gave everyone vitamin D because during the pandemic and lockdown, many of them could not go out and were not exposed to sunlight. So I gave vitamin D for all my patients. As Ravi said, I also gave vitamin C and vitamin in the first wave.
Sure. Keerat, did I see your hand or was it you saw
Yes.
your hand? Go on then. Quick comment, Keerat.
The immunity part, that the concept of boosting patients' immunity is very true, so much so that we have seen that suddenly zinc containing vitamin combinations have come up with names like immuno something. So it's been an essential part. And even if we don't prescribe, sometimes the patient will ask, mostly they will ask that should we take some multivitamin. So it's very important for the patient to feel he's getting complete treatment.
So did you know that in 2020, May, June and July, Do you know what was the highest prescribed drug in the country? The drug which generated the most amount of revenue in May, June, July 2020? Any guesses, guys? I'll take a brand name. I don't do that on a webinar normally, but I'll speak of a brand name. What's the largest selling drug May, June, and July 2020, guys? Quiz question.
Zincovate.
Zincovate. Bang on. So Zincovate. And you know, with the black fungus and the fact that zinc seems to promote the binding of mucor to the host receptor cell and increasing the penetration of the fungus within the cell, we now know that vitamins have harmful effects. So important message for the audience who sat there, please do not prescribe vitamins indiscriminately. Even if you do prescribe vitamins, do that for a certain period of time. So when you're prescribing, write something like 2 weeks on your prescription, write something like a month on your prescription max. Make sure that the drugs get stopped. Nothing is good for you on an endless basis. And I think that's an important carry home message for the audience. I'll come to Vishwesh with the doxy question, and I'll then tell you something interesting, Vishwesh. Vishwesh, doxy, where do you place it? How much did you prescribe it? How do you think it works in COVID?
So doxy, yes, I'm a proponent of using doxy, though there are multiple studies which negated. Even that principal study which was published in Lancet said that it didn't produce any amount of clinically meaningful outcomes. But rationally speaking, doxy is something which has been tried in many sort of atypical infections, and extrapolating its role in COVID is what I was following. And we are expecting some few positive results with respect to doxy. And I'd like to inform, like I was also a part of Dr. Raja Dhar's study on doxy, use of doxy in moderate COVID patients. So we are expecting the results of that study. And I found it very harmless, like no tolerance was good, and it covered the atypical organisms. So I was more keen towards using doxy, and even now I use it on patients who are not eligible for antibody cocktail therapy.
Sure. So thank you, Vishwesh. I cannot tell you the results of the doxy study as yet. I mean, I can do that on a telephone call, Vishwesh, but I cannot do it on this platform. But I think it's a promising drug. I think the reason we did not get positive results with doxy is because the endpoints that we recorded, mortality, etc., are difficult to achieve in small studies in COVID. And hence, I think with better done, more robust studies, maybe like the one we did a few days ago, I think you can expect good results with doxy. It's a good drug. It's got antiviral properties along with antibiotic properties. And I think it's something which is useful going forward into the third wave. What about ivermectin then? I have to say first, Keerat, that I am not a great ivermectin fan. That's one drug which I have never ticked. I don't have a tick box, but that's one drug that I have never ticked. I don't believe it works a lot, but I know a lot of my friends, colleagues have actually taken the drug. I know people have taken it for prophylaxis. So your take on ivermectin, which is a cheap drug, reasonably easily available, and about combining doxy with ivermectin. Your thoughts, Keerat?
So, sir, I feel that ivermectin, if you look at the rationale behind this drug, it's again a repurposed medication. It's basically an anti-parasitic drug, which was being used in the first wave. It came about while we were still early on experimenting. So it has properties. It has anti-inflammatory properties, and it has an action that it decreases, or it blocks the viral binding to the host cells, the binding of the SARS-CoV-2 virus to the human cells. So this has been proven in vitro studies, but the concentration required to achieve this effect is about 100 times the validated or the acceptable human dose. And if we look at the recommendations, say by the FDA, it is not FDA approved for COVID. We have been using it in India. There are two parts to this. One is that even though it is not approved, if you go online and find the studies, there are about 36 studies which will show that it has help in decreasing the viral load. It has helped in decreasing the duration of symptoms. It has helped in preventing worsening of disease, worsening of severity. And at the same time, we find studies which are saying that it was not helpful or no benefit, but no loss. It is relatively well tolerated. And in India, it is cheap and easily available. So when we did not have better facilities or better options before favipiravir, I was prescribing ivermectin because it made sense. It was one of the few drugs we had, and the FDA statement, they're very clear about it that ivermectin is not to be used. It is not approved for COVID. There's an important reason for that. The reason is that in US, people were getting ivermectin, which was for veterinary use. Ivermectin is not available over the counter in US. In India, it is available easily. So over there, people were overdosing on that, using veterinary preparations and coming with ivermectin toxicity. So I think now that we are at a better place, our approach has changed. But I am open to using this where, there are patients who will refuse even antivirals, who would refuse favipiravir because they would.
Fair point. I don't think we need to defend a drug. Neither we need to actually propose one, because none of the drugs are fully evidence-based. So all that we are talking about, so I spoke about doxy, we'll speak about favipiravir in a minute. So I don't think we are trying to pull down a drug. I think the reason we are discussing about all these drugs before we go on to discuss the cocktail is, I think going into the third wave or even further forward, there will be a place for all these drugs going forward. I don't think these drugs will fall into disrepute, because even if not for anything else, not all your patients or my patients would be able to afford the antibody cocktail. I think that's also something that we need to consider.
Even favipiravir, not able to afford.
Even favipiravir. Correct. Absolutely. Yeah. So your point is that you would prescribe ivermectin in a certain proportion of patients. And if you prescribe it, would it always be with doxy, or would you prescribe it by itself? Keerat?
I have always prescribed it with doxycycline.
Okay. So ivermectin plus doxy, and you think there's a position for this drug even going forward into the third wave, right?
For mild cases.
For mild cases. Of course, we're just discussing mild cases today, Keerat, so that's implied. So mild cases. I can see your hand, Ravi. Tell me.
Well, sir, just a small thing. Ivermectin is a repurposed drug, but just for public benefit, 10th February and 10th August are National Deworming Day. Days when you can actually prescribe ivermectin fully confidently in a very proper way. And I think that is where it still stands at this point of time.
Sure. So ivermectin. So let me go to Vikas. So Vikas, we'll talk about a few other drugs, right? So I can see some drugs that are there in the tongue twisting drugs, which are there in the question box, but let's start with easy ones. So your take on drugs like colchicine. So I'll name them one by one. So anything that you want to say about colchicine? We'll come to favipiravir last, because both Satish and I have a soft corner for that drug. So we'll come to that drug last. But so we'll start off with other drugs. So colchicine, anything that you want to say? Have you used it? Do you think it's worth the effort? Do you think it's a waste of time? What do you think? Vikas, mute.
Colchicine is our very old friend, and we are using this agent since decades. But we are using it in the gout, the treatment of gout. And the science behind using this drug in COVID, that it's an anti-inflammatory agent, and it's reduced the production of cytokinins, especially interleukin-1 beta. So it was postulated if the drug is colchicine, we use the colchicine in early stage of COVID, it can mitigate the inflammatory effect of the COVID. But a large clinical trial failed to achieve the endpoint of efficacy. So till date, there is no recommendation either in favor or against the use of colchicine in mild cases. But in severe cases, there is big no for use of colchicine.
Okay, so that's the theory, and it's very nicely put, Vikas. What would you do going into the third wave? In your list, would you tick colchicine or would you not tick colchicine for mild COVID?
So I will wait for other clinical trials. If any trial advocate the use of colchicine, then definitely I will use. Otherwise,
so as of now, no colchicine.
No colchicine.
Correct.
Yes.
Okay. 2-deoxyglucose. Your take on 2-deoxyglucose then?
Sir, 2-deoxyglucose is make in India drug, and we are very enthusiastic about this drug. Even frankly speaking, this agent also not a newer one. It was used initially for as an anti-cancer drug to kill the cancer cells, and it's act through the glucose metabolism. This agent having efficacy for the inflamed cell. It accumulates in the inflammatory cells and decrease the multiplication of virus. So, after the results of phase 3 trials, DRDO is very enthusiastic about this drug, and DRDO is advocating that it's very effective to reduce the duration of the disease, because it decreases the viral load. So the duration of disease is very less, and it's also very effective to the need of oxygen. So,
so have you used it? Have you used it at all?
Frankly speaking, till now, I
not used it. Anyone on the panel used 2-deoxyglucose? I can see a couple of hands. So let me ask Vishwesh quickly. Vishwesh, your experience with 2-deoxyglucose?
Yeah, we have been.
I'll come back to you, Vikas.
We have been using it for the almost last 2 months, sir. Like on patients who require oxygen and who don't have any end organ dysfunction, like a CKD or a CLD, or patients with uncontrolled sugar levels. We are using it. I wouldn't say that all patients improved, but yes, a very small fraction of patients showed improve, and it's very difficult for us to say whether the patient improved because of this or it's because of that's a common dictum in all COVID cases. But what we found is it is not harmful. So it is we haven't seen any serious side effects, except that you need to be wary of dysregulated sugar levels. You can have severe episodes of hypoglycemia, so you need to monitor that. And only for patients who require high flows of oxygen, we tend to use this drug, not for mild cases.
Okay. Anything to add, Ravi, to what Vishwesh said from a 2-deoxyglucose side?
Sir,
I'll come to you, Vikas, in a moment. Yeah, Ravi.
Sir, it has its own group of patients. I think it should be tried, because in several patients I have seen an actual improvement of at least 4 to 5% saturation on the first day. If you give it randomly in 10, at least 2 to 3 shows some improvement.
Okay.
Sir, I would want to add 2 things. First of all, this drug was recommended for moderate to severe COVID cases only. In the mild cases, its efficacy is not yet proved. And second thing, it was recommended that this drug should be used with other antiviral agents. So it's very difficult to know the benefit, which drug is causing the good benefit, whether it is efficacious.
Sure. Fair point, Vikas. But like you said, that is true for any drug that we use in mild COVID, simply because we keep combining drugs in the second wave. And I think that your 2-deoxyglucose license, you're right, it's not for mild COVID, but it's not for severe COVID either. It's probably for the moderate category of patients, sort of mild patients drifting towards severe. That's the category of patients where you would give 2-deoxyglucose. So this is an important moment in this webinar. Vikas, I will stick with you. I want a strong message from you about use or not for use of oral steroids at home in patients with mild COVID. I want a strong and clear message for the audience today.
Steroids should not be used in mild cases. Steroids should only be used in moderate to severe cases when patient is hypoxic and requires supplemental oxygen. All guidelines are saying that steroids should not be used in mild cases at all.
So Vikas, you would have seen that throughout the country, your colleagues, my colleagues, a lot of them have used steroids early on in the disease process. So tell us, why this reluctance from your side in prescribing steroids on day 3, day 4 of illness, when the patient has got fever? Don't you feel that the inflammatory surge might actually be inhibited by the use of steroids? Why do you not want to use steroids?
So first of all, steroids are having anti-inflammatory effects, not antiviral effects. So steroids should not be used in viral phase of disease. They should also be used in inflammatory phase of disease, that is in second week. If we use the steroid in early stage or mild cases, steroids can increase the multiplication of viruses. So there is science behind this. So steroids should not be used in mild cases or early phase of COVID.
So please listen to Dr. Vikas. Clear message. No steroids in mild disease. No steroids in early disease. It increases virus multiplication, virus replication in the upper airway, and hence will increase the viral pneumonia that you get with COVID-19. So that's a very strong message. Please do not use steroids indiscriminately. Let me come to Satish. Satish, question about favipiravir. You said you used a lot of favipiravir in the first wave. I actually used quite a bit of favipiravir both in the first and in the second wave. So tell me, what made you change your practice for not prescribing favipiravir in the second wave?
Okay, I mean, Raja, as you said, first wave, I used a lot because there was nothing, and I was very impressed with one of the study that was done in India, and one of the only study with our colleague Zarid used to say that this type of study can be, if it can be done in India and replicated, I think we are in for a good number of studies which can highlight the effectiveness of any of the drug. And going by the data and some recovery and used by many other countries, which were also there in their national guidelines. So I used it in the first wave. Now the second wave, I felt there was not much data, and which were robust when we studied, which were robust. Anyway, patients were improving, and we were also learning more about the viral dynamics and the inflammation which occurs in these patients and how to deal with these patients. So we were becoming stronger. And I was of the opinion later in the second wave that it might not have made much difference to patients. So we used it anyway in the first, and there was not many trials were going on, not many data were coming up. There was a big study which was supposed to be done in Canada, and the recovery also was supposed to recruit patients, but then nothing came out in the end. So I was disappointed that the not many trials were done. At the same time, that I was happy that the many countries thought that it was not worth looking at to this molecule. So I didn't use it, Raja, frankly, in the second wave at all. Not even one patient.
No. So fair point, Satish. I think there is, like we said, no right or wrong answers. I'll tell you my rationale. So with favipiravir, I think this is a viral illness, and it's almost implied that an antiviral should have the best effect in a viral illness. So that was my rationale. I tend to use an antiviral as early in the disease process as possible. I would use it in very mild and mild disease. I have not really used it in moderate disease. I don't think the drug actually works in moderate disease, but I think it reduces duration of the disease. The duration of disease, the viral replication gets reduced by favipiravir. So I'll give you my little take, and I want all of you to give your thoughts about this. So what I use a basic phenotyping principle for COVID-19 mild disease. So if the patient came in, was young, relatively well, a bit of fever, maybe a little bit of upper respiratory symptoms, up to day 5, I would give them favipiravir alone, along with a vitamin and the symptomatic management in the form of paracetamol, etc. If the patient was more elderly, had comorbidities, I would actually combine a doxycycline to the favipiravir and give favipiravir, doxycycline, and the vitamins. This we're talking about the first wave. I'll come to how the second wave was different for me in a minute, but I would combine the favipiravir and doxy. And I guess if I was ivermectin prescriber, this is the population of patients where I might actually also put in the ivermectin, given the fact that the comorbidities would put the patient at a higher risk. In the second wave, like Satish pointed out, all the patients with early disease, I was very influenced by the STOIC trial. Being a pulmonologist like all of us are, I was comfortable giving an inhaled steroid. And I think the fact that it reduced the inhaled budesonide reduced emergency visits influenced me a lot in prescribing inhaled budesonide to most patients. So it would either be just inhaled budesonide, or it would be inhaled budesonide plus favipiravir, or it would be adding in doxy to this combination when I prescribe drugs in the second wave. So thoughts, guys, that's my phenotyping. There is absolutely zero evidence for it, no evidence at all. But that's what I have done in my own practice. I would want to know whether this is the message. We'll come to the cocktail in a minute, but is this the message you guys would also like to give? Do you think it should be a little different? Do you think we should not give anything at all? So your thoughts going to the third wave, SAN antibody cocktail, what would your prescription consist of? Any differences, any thoughts? Anyone?
Raja,
Yes.
can I come?
Yeah, please, Satish.
Yeah, Raja, I think going to the third wave, potential third wave or the next wave, I think we are on the robust side of the scientific facts that definitely I'm not going to use. To be short, not going to use favipiravir or doxycycline or any of those. Definitely no. In mild.
And if you have a trial on favipiravir or on doxy, would it make it change your mind, Satish?
Yeah.
Suppose you had a trial which showed good evidence.
Yeah.
So, you would go on to use it. Okay, fair enough.
True. I mean, we were all surprised.
Sorry, Satish, I think you're breaking up. I don't know whether that's just for me or for the others too, but I can't hear you consistently.
For example, tocilizumab, again, same thing happened. So we all changed whenever there was robust evidence, whenever there was scientific evidence, and then the trials showed good data and good impact. We all changed. We are definitely. I'm hopeful that there will be something on ivermectin because, as you rightly said, it's cheap, easily available, and anybody can use. And even though anecdotal, studies which are there, which are showing that some impact. So I'm very open. Whichever proves that it is going to be effective and cost effective, especially for a country like ours.
You're going to stick to the inhaled budesonide, though. That you're not going to give up on.
No, and we used it, Raja. As you know, all of us used it in the first wave itself, not knowing that what dose to be used, and then later the trial, including the principal trial and then the Oxford trial, showed 1,600 microgram.
Yeah.
That's when all of us changed to 1,600. I was using 200 microgram twice a day and things like that.
Yeah.
So that became very clear. And I'm very fond of that because we have used this for any viral related so-called reactive airway disease and we have used it with some success.
Sure. So a strong vote from Satish's side for inhaled budesonide, 800 milligram twice a day to be given. Please ask your patient to wash their mouth properly post giving the dose. Otherwise, you hear about mucor again. So that's an important message. I can see Ravi's hand. Ravi.
Well, there are two things, sir. First, importantly, I would like to pass on a message which Dr. Krishna, sir, often says, what you also told, sir, echoed that sentiment, that there is no drug of choice yet. But when there is no option to write anything to a patient which is not harmful, at least writing something boosts the moral and in turn the actual drug confidence of the patient. So in a way, it's good to prescribe something at all. So I think it echoed with what your sentiment, which Dr. Krishna also wants to convey. And the second thing is, sir, one thing which I cannot want to improve more on is improving and including a lot of research in my own practice. Because if I look back and I would just say that if I would have actually documented things, then maybe I could have had solid evidence to say a lot, which I'm not able to do just now.
Stands true for all of us, Ravi. Fair point. Keerat, quick point. We need to go to the cocktail.
Yes, I think the fact that we have all here used all of these drugs and still seen patients worsen and go from mild disease to moderate to severe shows that there's a gap. And the fact that we cannot give up on mild patients saying that they're going to be fine either. So there is a place for all these drugs.
Sure. Agreed. Fair point. So let me come back to the cases now. That's how we go into the cocktail discussion. And we've got about 20-25 minutes for the cocktail discussion, and then we'll take audience questions. There's a lot of questions in the question box already. So let's, who was the first person who presented? Was it you presented first, Vishwesh?
Yes.
Yeah. So Vishwesh, give us a 3-line summary of the case so that we can then go on to the case itself.
So he was a 70-year-old male with diabetes, hypertension and CKD with a 4 days history of fever and cough, with CT apparently normal, with COVID RT-PCR proven positive. So he was on treatment with doxy and ivermectin, referred for pulmonary consultation. So we gave antibody cocktail therapy and patient showed effervescence of fever within 2 days. And on follow-up till 10 days, the patient did not show any signs of worsening. So this was the gist of the case.
Sure. So Vishwesh, a few questions for you before I sort of open it to the panel. Was it only the antibody cocktail that you prescribed to this patient?
Yeah, because he was already on doxycycline, so we stopped it. Once we put antibody cocktail, we don't give any other drug because we believe that it works.
Okay, wonderful. The other question I wanted to ask you was your rationale for prescribing the antibody cocktail in this individual, or is it that any patient who comes to you now, you would offer them the antibody cocktail provided they have mild disease?
So the recommendations by the FDA are pretty clear. It is not for all mild cases. So you need to choose the high risk factors. Patients who are more than 65 years of age, patient having underlying comorbidities like diabetes or a hypertension or a chronic respiratory disease, or patients who are on immunocompromised state, CKDs, CLDs, and even patients on immunosuppressive therapy who cannot mount a response, or for post-exposure prophylaxis for high-risk groups, for people who are more than 12 years of age, then only we prescribe the antibody cocktail. So it is not for all, but I feel that extrapolating the scientific rationale, maybe in the future, the age criteria might go away, and we may have even for patients less than 65 years of age. Because the scientific rationale is very clear. Maybe this is for triaging the available resources. So we are targeting high-risk population. But I think in future, the scientific rationale is that you have a virus, you give an antibody, the antibody kills the virus. So why not give it for patients even who are less than 65 years of age?
Okay. Okay. So the other question I wanted to ask you, and sort of again a message for the audience, Vishwesh. This patient came to you on day 4, I think you said. So day 3, day 4. Suppose this patient came to you on day 7, day 8. I know the license of the drug is till day 10. So, but would you have the same degree of confidence in giving the cocktail on day 7, day 8 as compared to day 3, day 4? Or would you change a little bit in the way you prescribe the drug?
So I would look for saturation levels. If the saturation is normal and patient is not having significant breathlessness that is suggestive of underlying pneumonitis, then yes, even till day 10, I would give, because the benefit of the drug is more than the side effect. So I would give the option till 10 days, even though it works best within the first 7 days.
Okay. Okay. And one last question to you, Vishwesh, and I'll go to the panelists after that is, I noticed that in your case, you mentioned that the H1N1 was negative. I found that very interesting because, you know, we've found in all cities throughout the country that during the second wave, there's been a lot of influenza, specifically H1N1, but even other strains of influenza. So is it normal practice for you to check the H1N1 when someone comes in with fever along with doing a COVID RT-PCR? Or was there something different in this patient which made you do the H1N1 test?
So in Telangana, it works like that. The H1N1 can be sent only when the patient is hospitalized. So it becomes for any patient who gets hospitalized with COVID-19, suspected COVID-19, we send H1N1 concurrently, because we are seeing cases of not H1N1, we are seeing cases of influenza A as well, which comes in the report. So for all hospitalized patients, yes, but for non-hospitalized patients, since we have logistic issues where we cannot send H1N1, we just go for a COVID RT-PCR and an antibody levels.
Okay. Okay. So strong message there, guys. So I think, I mean, we don't send H1N1 routinely in everyone, but if the COVID RT-PCR came back as being negative, we would definitely do an H1N1. But that's not to say I disagree with you. I would probably change my practice, Vishwesh, and I would check for influenza first up, because there's a small percentage of patients who have a co-infection, isn't it? So you could have COVID and influenza at the same time. And we've seen a few patients like that in our practice. Let me come to you, Ravi. Same case. We're still talking about Vishwesh's case. But I noticed that this patient had CKD. So message for the audience again. Do you think having chronic kidney disease, being on dialysis, having liver failure, any of these impacts the prescription of the antibody cocktail in any way?
Well, frankly speaking, it reinforces the fact that you have to give antibody cocktail to that patient if he has a set of comorbidities which fall into the high risk group, like CKD, chronic liver disease, being on dialysis, elderly, diabetics. Then it is all the more reason to go ahead and prescribe cocktail, because it offers safer protection even in the presence of these diseases.
Okay. And sort of another message again to sort of hammer home, no dose adjustment needed. In chronic kidney disease, liver disease, you don't need to adjust the dose in any way.
Absolutely not. That is the most beautiful part about it. And really, it takes a load off your mind also, because you have to give it in the same way that you can give to any other patient.
Okay. Okay. And sort of similar question. I mean, Vishwesh has already answered this question, but I'll put it to you again, Ravi, to reinforce the point. So suppose this patient, the patient that Vishwesh described, just had diabetes, right? And had everything else, or did not even have the diabetes. Would you still be inclined to prescribe the, or at least offer the antibody cocktail to this patient going into the third wave? He spoke very nicely about the fact that at least physiologically, mechanistically, the antibody should work even in the category of patients who are not high risk. So would you be tempted to use it in people who can afford the drug, or would it not be something that you would consider?
No, sir, I would frankly prefer that we give this cocktail to a patient, even if he's out of the high risk category, because we never know how things will turn about with COVID. So, if we have an agent which guarantees some amount of assured protection, we should go ahead and use it. At least it can even help in cutting down on severity. It can help in many ways that we still are understanding. But if given a choice, I would like to use it in most of my mild patients who present early.
Okay, grand. So, let's move forward. Let's go to Keerat's case. Keerat's case presents a different facet. So Keerat, a quick 3-line summary similar to what Vishwesh did for your case, please. Then we can move forward.
So this was an online consultation. Patient was 53-year-old gentleman who was not stepping out of the house. So he was very careful about that. He had a history of fever since past 2 days, 101, but which was responding very well to paracetamol. And he had already gotten an RT-PCR, which was positive, and even got a CT scan from a local setup. CT severity was 5 out of 25. And he was the only comorbidity was he was hypertensive, and it was well controlled. He was particular about his medication. And he had OSA, and he was using CPAP since the past 3 years. He received first dose of Covishield, and second dose was due in about 20 days' time.
Sure. So the vaccine is the interesting facet in your case, and we'll come to that, Keerat, in a moment. But before that, you asked this patient to come to you to clinic, right? Because you thought this patient might be appropriate for the antibody cocktail. You did not?
No, I asked him to, I actually chalked out the management plan with him. I told him that he should get his blood tests done. He needs to document his oxygen level and do a 6-minute walk test as well. And I primed him about the options of using an antiviral and the fact that he could benefit from antibody treatment, which we would, and I fixed him up for a review consultation online.
Okay, so you did not ask this patient to come in person to see you in clinic?
I told him about the options. I wanted to review with his blood tests, and I asked him to look up. There are a lot of testimonies also, and patients who are so well read and who are consulting online were so careful that they're not stepping out of the house also. I also don't want to give them unnecessary exposure.
Sure.
I would rather.
I'm not for a moment. So Keerat, I'm not for a moment suggesting you should have asked the patient to come for I'm just asking whether you did or not.
No, I did not.
You did not.
I told him about the options and gave him the time to look up the option of antibody therapy as well. And there are also, let me just mention it here, that there are a lot of testimonies available online from people who have received antibody therapy and responded very well.
Okay. So Keerat, very fair and very nicely explained. So whom would you ask to come physically to the emergency if you see them on an online consult? So, I mean, there's a category of patients, not this one, but there's a category of patients whom you see and say, okay, this patient should come to the clinic. So one point I'm sure you would mention is hypoxia. So any saturation which is sort of drifting southwards, you would ask the patient to come down. But aside from this, any pointers for the audience as to which patients on an online consult should come to the hospital, should come to the emergency?
So when there is hypoxia, and then it means that there is disease worsening, going towards from mild to moderate. We are currently only talking about mild COVID. So I would always, and do tell the patients that they must do a 6-minute walk test every day. If there's any dip in their saturation level on 6-minute walk test, then I might want to get a repeat CT. So this patient had, say, CT score of 5 out of 25. It is mild right now, but what about 5 days down the line? It might worsen. So I would actually want them to come. I would want to give them a list. This is what I do, a list of alarm signs that they should watch out if they have any breathlessness, any cough, any increase in cough, any fever that is not remitting, fever that is not touching baseline. And like in this case, patient was responding well to paracetamol. Any fall in saturation, any increase in oxygen requirement in patients who might already be on oxygen therapy. So I would ask such patients to come down, and maybe even if they're mild cases and if they're at high risk, I would want that when they come, they should be primed for the antibody therapy and they come and receive it also.
Sure. So a couple of points I may want to make, Keerat, and this is not disagreeing with what you've said at all. We have said that in COVID, I think everyone has a perspective which might be slightly different without the other person being wrong. So one message I want to give the audience is that not all your patients need a CT scan. I think that's important to remember. Not all your patients that with mild COVID at home need a CT scan. I couldn't agree more with Keerat's point about getting patients to walk at home and recording your saturations. And I want all of you out there listening to us today in the third wave to go ahead and ask them to walk. Even if they don't manage a formal 6-minute walk test, get them to walk for a couple of minutes, put the oximeter on, see whether saturations are dipping by more than 4% or whether the saturations are going below 90. And I think that would be an important signal for early hypoxia, and patients should come into hospital at that point of time, because we know that it's at the onset of hypoxia where we intervene, we have the best results. So I think that's very, very important to remember. I probably wouldn't repeat a CT or do a CT just because the saturations are coming down on walking. I think probably a CT would wait till the patient actually gets admitted in my book. But again, there's no evidence either way. So not for a moment am I saying that what Keerat is saying is wrong and what I'm saying is right. But my approach, being slightly more conservative, would be to do a CT maybe at admission in patients who would get admitted rather than doing it when they're at home. And the one point I want to make, while agreeing with you, Keerat, about giving patients the options and thinking, is that there's a degree of urgency about giving the antibody cocktail. So we have to give them a time frame. So give them the choices, all of you there, give them time to think, but the time should be maybe 24 hours and no more than that, because if you vacillate and wait for too long before you give the cocktail, the chances that the drug is going to work is going to reduce by a fraction, a small fraction, but still reduced by a fraction. So that's another message that I wanted to give. Another question I wanted to ask you, Keerat, was, you said that the CT score was 5. So you did a CT. So this is going against...
I did not do a CT. The patient already had it.
No, it's okay. So the CT had... So my question is different. So the patient had a CT. CT score was 5. So this is actually contradicting what I said a little while ago. But suppose this same patient had a CT score of 14. Okay. So hypothetical case, CT score of 14. Would it influence your choice regarding admission? Would it influence your choice about giving the antibody cocktail? Would you actually admit the patient and start the patient on remdesivir based on a CT score of 14? What would your approach be? So you walked the patient, suppose, and the patient does not drop saturations by more than 4%. You walk the patient at home. What would your advice be? Because we've seen patients like this, high CT score, low symptom burden. What would you do on those patients?
I would like to see his inflammatory markers.
Okay.
And I would want to admit him.
Okay.
And I would have, in the previous, pre-antibody time, I would have probably gone in for remdesivir also, okay, after evaluating for markers. But in this case, now I would maybe, because he's come to me early, and if at day 3 he's having 14 out of 25, I would be very concerned. Sure. And I would like to go in for antibody therapy quickly, because the results are quite remarkable. We've seen that patients are showing reversal in 6 hours, 12 hours. And for all other agents, all the trials, we have a very significant confounding factor. Remdesivir always has been given with steroids. Other drugs always given in combination. There's no way saying what is working, what is not. We just know that steroids help. So for that matter, I would want to go in for antibody therapy quickly. And what I did in this case is I told him that I need to review with his labs. In the meanwhile, I gave him the time to think about the antibody, and I primed him that this is a good option and he would benefit.
Sure. Grand. So completely in line with what you said, Keerat, about getting this patient. So I think the exceptional patients where CT is of high discriminatory value is where the CT score is above 14. I have, and I'm sure there's people in the panel would agree with me, seen that these patients almost invariably get worse and become hypoxic in the disease course. And I think it's got very good discriminatory value when the score goes above a certain level. So I'm not so sure about the cocktail. So my personal experience with the cocktail, I've given it to about 25 odd patients till date, is that once the patient becomes hypoxic, if you cross that bridge, the drug does not work that well. Having said that, there's trial evidence which shows that it does work even in the hypoxic section, but not in my personal experience. And let me ask people who have prescribed the cocktail. I'll come back to you, Keerat. Let me get some other people into the discussion. So anyone, your thoughts about patients who've got a high CT score or on the verge of becoming hypoxic, 1-2 liters oxygen requirement, thoughts about the cocktail? What would you do going forward? Yes, Vishwesh.
So here, generally we don't do CT on the early stages. So this discrepancy generally doesn't come within the first week. So when we do the CT scan, when the patient is either hypoxic or patient is having increased breathlessness, and if the CT is showing a presence of pneumonitis, then my approach would be to go for a remdesivir with a steroid and an anticoagulation rather than going for a monoclonal antibody. Because right now, probably the patch, what we are seeing is secondary to the inflammatory aspect of it rather than just the viral phase of illness. Another point is the use of antibody cocktail in a patient who is already admitted in the hospital. It is very clear that the response was seen in the study only who are seronegative. That means they were not able to mount an immune response. But that fraction of the population, even we tried to actively screen for all our patients in ICU and wards with antibody levels, most of them would have had a IgG response by that time. So sure. It's a very probably a very small fraction of a patient who are not mounting an antibody response. And that subset of population, yes, there are guidelines where they say that you can still give monoclonal antibody because that will help in increased viral clearance and decrease in the duration of the hospital stay, and it decreases the mortality by around 6%. But in my practical experience, that proportion of the patient is almost negligible. I have not even able to see one patient who has not mounted an immune response after having a COVID-19 infection.
Sure. So I'll come to those questions. Vishwesh, you've stolen a little bit of our thunder, but I can see Ravi's hand. Ravi, you put up your hand. Is there a point you want to make quickly? And then I'll come to the vaccine question again.
No, before I would say convalescent plasma therapy was banned, sir. In such a subset of patient which Keerat has mentioned, we would have straight away gone ahead and given convalescent plasma therapy. So taking a cue from that, I still feel that giving antibody cocktail, which works on broadly the same principle, will offer some benefit to that patient, sir.
Okay, fine.
So
Satish, Keerat, I'll come to you after Satish. Just one moment. Satish.
Raja, I haven't used cocktail antibody in patient who are hospitalized or hypoxic, but the data shows that the dosage must be much more than what we give for these individuals. It's about something like 4 grams, and what we are giving is 600 plus 600, 1,200. So that's supposed to work, and not the regular dose that we give for mild patients in the outpatient.
Thanks, Satish. That's a very valid and important point. Keerat, you had a quick point.
Sir, only that if there is oxygen requirement, antibody cocktail is not recommended. So that is the statement from NIH so far. So
yeah, but
we are only looking at 14.
You know about the new trial, Keerat. So that's what we are all talking about. And I think Satish there's a question in the question box about the dose. So guys, you've heard the dose there. 600 plus 600 milligram is what Satish said just now. The higher dose is not something any of us have used, but I have used the lower dose, maybe wrongly, in one patient who was hypoxic, and one patient is just one patient. But I just feel that the same dose will not work in patients who've just become hypoxic, like Keerat said. So that's an important point. Let me come to the vaccine question. Vikas, you've been out of the discussion for a while. Vikas, so this patient, Keerat's patient, had 1 dose of the vaccine. So in this scenario, I mean, going forward into the third wave, hopefully almost all our patients would have had at least 1 dose of the vaccine when they come to you with mild COVID infection. That's the phenotype of patients all of us will see. So your thoughts about giving the antibody cocktail to these individuals, and then I'll come to 2 doses of vaccine in a moment. But 1 dose we'll talk about first.
Scientifically, the antibiotic cocktail should only be used in seronegative patients. But the guideline says patients who are having mild COVID, who are not fully vaccinated. That means there may be some space for the patients who received 1 dose of vaccine. So ideally, before using the antibody cocktail in patients who received 1 dose of COVID, we should do the antibody titer. If patient having significant amount of antibodies, we should not use the antibody cocktail. But if the patient not having any significant level of IgG, we can use, or we should use the antibody cocktail in these patients.
So Vikas, here lies the problem. So 1 dose of vaccine, you can consider using the antibody cocktail. I completely agree with you. The challenge is measuring antibody titers. You do an IgG antibody. What is there to say that the IgG antibody is the only antibody in question when you're looking at seroconversion and immunity in patients with COVID-19? So that's the challenge. So I'm not sure whether we have, and Keerat had very beautifully asked these questions in her presentation. I'm not sure whether she actually presented the case along with the questions or not. She did. So I can see her nodding her head. So beautiful question. So what antibodies are we measuring? Are they the relevant ones? What is the cutoff? What is a good antibody titer? What is a suboptimal antibody titer?
So still there is a gray area, but usually the patient is having antibody level, IgG level below 2. It's, I think, insufficient antibody. And if patient is having antibody titer, IgG titer is more than 8 or 10, it is sufficient number of antibody. But still there is a gray area. Which level should we consider that the patient is seroconverted or not?
And there's a lot of labs which do total antibody levels. I am sure you would have seen that with us. It says total antibody level and comes up with a number. Do you think that might be more evidence-based given the fact it's total antibody rather than just the IgG?
I think IgG is more evidence-based.
Okay.
Because
IgG
there is a lot of difference that levels, different labs are giving different levels of total IgG.
So let's come to the scientists in our group. So I'll go to Satish. Satish, what are your thoughts about the antibody level and giving people the antibody cocktail based on antibody levels? 1 dose of vaccine, 2 doses of vaccine.
Okay, Raja. The antibody titer doesn't matter at all when you really think about giving the cocktail antibody. And very early on the cocktail antibody webinar, Professor Bassetti, I think from Italy, who had a lot of experience, he was mentioning the very fact that after vaccination or, for example, antibodies, the patient has developed a COVID-19 infection, it means that you have to give these patients the cocktail antibody. So cocktail antibody doesn't decide the antibody titer. So I am not in favor of doing an antibody titer and then measuring the antibody, whether it is 2 or 20 or 30, and then to give patients the cocktail antibody. First vaccine, second vaccine doesn't matter to me, as the evidence says. And I have given for patients who are fully vaccinated and developed and they have comorbid conditions, because vaccination is not 100%. We all know that it works like 80%, 90%, depending on the vaccine that we use. So I have offered to all those patients who are fully vaccinated, all those patients who carry a risk of, potential risk of progressing to a severe disease, I've offered them and given them when they could afford the cocktail antibody, Raja.
Sure. Satish, fair points. The two different divergent views. I'll give you my view and then I'll ask others, because I think this is a crucial question. The giving of the drug in the third wave will depend on the answer of this question, I think. So the rationale, I think, the very simplistically put, the rationale is you've had vaccine, 1 dose, 2 doses, you've got antibodies in your bloodstream. The site where the antibody cocktail is going to go and bind to is already been occupied by the antibody that you've got in your bloodstream. So how is the drug going to act? So Satish's point, very rational, is that if the virus can actually replicate in your upper airway, in your nasopharynx, obviously the titer of antibody in your blood cannot be enough to give you protection. That's what Dr. Satish is talking about, which I think makes some sense. However, in my book, I would have greater reliance on giving the drug, the antibody cocktail, in people who are unvaccinated or at least with 1 dose of vaccine, as opposed to those who have 2 doses of the vaccine. In my understanding, I agree with you, Satish, that measuring antibody probably doesn't make a lot of sense because we don't really know which is the valid antibody. I can see our good friend, Dr. Rakesh Chawla, there in the question box asking which antibody. So I agree with you, Rakesh bhai. I think the antibody type does not really matter because we don't know what we are measuring here. Any other thoughts? So Ravi, yeah, Keerat, go on.
So I would like to say that even if there are some circulating antibodies, first of all, for all the vaccine trials, still we do not have a validated endpoint antibody titer. So there's no way that we can determine what titer is sufficient. The normal lab range that is given, that is not enough to say that it will produce enough immunity. Second, there may not be competing epitopes. See, for both the monoclonal antibodies we are giving in this cocktail, they are acting on the S protein at non-competing epitopes. They are not competing, which means that if we are giving a cocktail antibody to patients who might have some circulating antibodies, they may not be competing. And that is the reason that the other earlier antibodies have gone out of repute in US because they were being given individually, first of all. And here we are giving both of them together. They are not competing and they're working synergistically. And they have covered strains together, which they were able to neutralize strains together, which they were individually not able to do.
Sure. So fair point. So let me come to Vishwesh. Vishwesh, so you got this patient, third wave, you are on the 18th of October, and you have this patient who is coming to you, the same patient that you had before. But this patient is now doubly vaccinated. And you have the option of giving this patient the antibody cocktail, double vaccinated patient, versus giving the agents that we talked about a little while ago. So the favipiravir, the ivermectin, the doxycycline, the inhaled budesonide, and so on and so forth. What is your option likely to be? And give us a couple of reasons as to why your answer is the way it is.
So with respect to the mild COVID, there is absolutely no doubt, even as per the FDA recommendation, you need not measure antibody titers at all. It's all about high-risk population or people with less than 65 years of age with comorbidities. That's it. There is no criteria to measure the antibody levels for patients who are having mild COVID. The real problem of assessing this antibody titer comes to play only when we are dealing with a patient who is in an ICU or who is in a HDU requiring oxygen, where the point comes like whether antibody will really work on these patients or not. So the study, what they did, they had all the 3 arms, one patient who had seropositivity, one patient who had seronegativity, and one patient whose antibody status was unknown. What they found in those hospitalized patients with seronegativity, the antibody brought about a significant resolution in the clinically meaningful outcomes. So I would reserve this measuring of this antibody titers only when I want to give this antibody cocktail for a hospitalized patient. For a mild patient, him vaccinated or not vaccinated, I wouldn't go for measuring these antibodies to give an antibody cocktail therapy.
So would you give it or would you not give it? Is the question.
I would still give it because his age is 70. So I would still give it because he's in a high risk.
Okay.
What effectively means is like patient got vaccinated, still he is developing COVID. That means that he has a waning immunity. Probably these antibodies are not protective anymore.
Correct. So we have to give a cohesive message about this because I think this is the most crucial issue for the clinicians. I can see lots of questions in the question box. So would you say that the threshold for giving the antibody cocktail is not determined at all by whether the patient has been vaccinated or not? Or do you think that your threshold of giving the antibody cocktail would be highest in people who are unvaccinated, a little bit lower in patients who've had 1 dose, and even a little bit lower in people who are vaccinated? Do you think that's the case, or do you think it's all across the board, given the fact that these patients are getting mild disease in spite of having had the 2 doses of vaccine, we should go gung-ho and offer the cocktail to everyone? What's the message?
Very clear, mild disease, no need to look at either vaccination or antibody titer levels. Just look for risk factors and age factor.
Yeah.
If it is there, go for antibody cocktail.
Yeah. I would probably personally be a bit more cautious, Vishwesh. I think the license, even from the ICMR, for the antibody cocktail till date is for the unvaccinated population. I agree with you. I think the rationale, what you're saying is perfect. But I think in the vaccinated population, I would probably look for comorbidities more, risk factors more. I would look at the age to a greater extent and preserve it for that population who I would really deem as being high risk without the hypoxia, without getting admitted to hospital. That's the population I would reserve it for. Otherwise, in the vaccinated population, I would still prefer giving the antiviral drug in this population. Wait for the doxy trial studies, but I I cannot help myself but say that the results are actually very promising. So I think these will be drugs which will come in. The inhaled budesonide, which Satish and I am a big fan of. I think that would be probably higher up in my preference list in this younger lot of patients, no comorbidities, less comorbidities early on in the disease. I probably would prefer the antibody cocktail for unvaccinated population in this group rather than the vaccinated population in my thinking. Ravi, any thoughts about this before we move on and take questions from the question box? Anything that you want to add?
No, I perfectly agree, sir. One important group that we also should talk about is the recently vaccinated. If you are vaccinated and it's hardly been 2 to 3 weeks, I think we can again go ahead and prescribe antibody cocktail in them very confidently, because that is one group which often ends up in the hospital at times.
Sure. So Keerat, I'll come to you in a moment. You can say your message. We need to move on. So Vikas, subcut versus IV. There's been 2 different studies, subcut, IV. What route would you choose and why? What's your message to the audience? What should one single route, please, not different routes for different patients?
Ideally, it should be given by IV route, IV infusion. But this is drug for mild COVID patient. So we can use this drug in even in OPD setting also. So in a pandemic condition where there is a huge rush in OPD, I think you can't offer the half an hour to 1 hour to each and every patient to administer the drug. In that condition, you can use the subcutaneous route also, or even the second class of patient where to get an IV access is very difficult. In these patients also you can use that subcutaneous route, but ideally it should be given IV infusion. So there are some few conditions where you can use the subcutaneous route.
Sir, just one, if I'm permitted, sir.
I think connection lost.
Yeah, so I'll just utilize this time to announce one piece of good news. We have crossed 1,107 logins for our webinar, and a good hats off to Team CCI. Thank you.
Yeah, just to say, I've taken permission from Dr. Viswesvaran that he is in the hospital, in the ward, admitted for a lower respiratory infection, community-acquired pneumonia, and look at his spirit, look at his enthusiasm. Just like Raja, when he was down with COVID, nothing has happened. He's sitting in a house. He's sitting in the hospital. And I also saw the nurse peeping outside his room and coming in to give probably an IV. Hats off to you, Viswesvaran, and all the best and speedy recovery.
Yeah, thank you, sir. Thank you. So now experiencing what I am preaching. So,
but well done.
No, it's going on. It's going on.
Thank you.
Now, to carry on with the webinar part, sir. Sir, or maybe family contacts. So, Satish, sir, if you would like to comment on that, sir.
Okay, Ravi, it's a very interesting question. Somebody who's asymptomatic, who's positive. We are talking about mild. we don't know what will be the turn of events for this patient in the future, after 3 days, after 5 days, after 7 days. And if he has, as we all discussed, whether vaccinated, not vaccinated, has comorbidities, which puts him at risk from developing a severe disease, I think even asymptomatic individuals must receive, if they can afford, or offered at least, a COVID antibody, no doubt about it. And Ravi, other question was about
Contacts, sir. Family contacts means susceptible, close contacts.
So very interesting data has emerged in the last few weeks or months, probably, that post-exposure prophylaxis, these patients who are at high risk at home and are exposed knowingly or unknowingly, tested positive or negative, doesn't matter if they're going to test later, you can offer them post-exposure prophylaxis simultaneously. I've done just that with one patient yesterday. The wife is positive, she has risk factors, and she's fully vaccinated, and she was offered and she took it. And the remaining half which was there was offered to her husband, who is also 70 years, and given to him the half that was remaining. So excellent data emerging from the post-exposure prophylaxis. I think it's a good thing to offer to patients who are at high risk, Ravi.
Yeah.
So Satish, just to add to what you said, the data emerges in this country more than others because, you've got one half of the drug, which you have to give because the patient has brought 2 doses, and you end up giving it to contact. So we've actually got about 100 patients throughout the country where we have collated data for asymptomatic individuals, and we're going to send it off in a few days' time. But it's interesting that because of the design of the drug, the way it's actually been developed, we can develop this data for post-exposure prophylaxis in this scenario. Ravi, any other questions you want to bring up, or shall I? There's one question that I sort of want to ask Vikas. Maybe I can't see. Is Vikas there?
Is there?
Yeah, Vikas. Hi. Yeah. So Vikas, question for you. Do the mutant strains in any way influence your decision about what drug to give, including the antibody cocktail? Do you think there's any relevance of knowing the mutant strain? We keep talking about Delta plus. There's mu now yesterday. So that's the news in the market. So any thoughts?
So one thing I want to say clearly, that genome sequencing is still not easily available thing in our country. It's available only in research purpose till now. It's not commercially available. So it doesn't affect my decision to treat my patient. I should stick to the standard protocol. But some studies, early studies, says that this antibody cocktail doesn't work against the Delta or Delta plus. But it's too early to say something till then the further results are come. So we should stick the standard protocol of treatment in these patients.
Okay. So I will agree with you completely, Vikas. I will probably give a slightly stronger message. I think even if genome sequencing was available to us, my prescription of any drug in the COVID-19 pandemic would not actually be influenced by what the genome sequencing is. I don't think the mutant strain actually changes our prescription to any extent. So I don't think it's relevant to our prescriptions as such. Let me take some questions from the question box. This is a very interesting question, Ravi, from Dr. Behra in Odisha, who says, after how many days can you, after the first dose of COVID vaccination, can you actually receive the cocktail antibody for mild COVID infection? So I think we've discussed this, but again, I don't think we know an answer, but any thoughts, Ravi? So suppose you had the vaccination. There's a lot of patients you have seen who've had the first dose of vaccination and then landed up in the emergency with mild COVID infection with a bit of fever and nasopharyngeal swab.
Yeah. Means I can just say that initially they used to give Covishield at 4-week intervals. So maybe let's consider 4 weeks as a standard duration. Anything under 4 weeks after a single shot of vaccination, maybe you will be considered as recently vaccinated. Will not up. So you can.
Ravi, I couldn't hear you very well. I don't know whether others did or not, but I got the essence of what you said. Let me move on to another question. There's our good friend, Dr. Parikshit Thakre, who's asked quite a few questions. I'll ask one of them. I think this is important for the audience. Side effects after using the cocktail. Let me answer on everyone's behalf, and you can differ, anyone in the panel, if you have any other experience. I have always found the cocktail to be an extremely safe drug. I've hardly had any side effects from using it. You've talked about seizures and refractory arrhythmias in 1 or 2 patients. I am not sure whether the seizures and refractory arrhythmias were caused by the COVID-19 infection or was caused by the antibody cocktail. I would prefer to think that it was actually the disease process which caused it rather than the antibody cocktail, which I would reckon is very safe. Any thoughts, anyone on the panel? Would you agree with that? Satish?
Yeah, Raja rightly said so. It's one of the safest drug one can administer for COVID. There's no doubt about it. And all the data showing, even though there's some mention about anaphylaxis and allergic reaction, some nausea, headache, all are self-limiting. And we haven't had any patient who's complained about it. So it's one of the safest drug, definitely not known to cause arrhythmia, not known to cause any seizures. I think, as you rightly said, it may be related to COVID or any other reason rather than COVID, the cocktail antibody. One of the safest.
Sure. Grand. So there's
hello, excuse me.
Yeah, Krishna bhai. Hi. Good to see you. Good to see you.
No, I beg a kind interruption here. Am I audible?
Welcome.
Loud and clear. Go on, Krishna bhai.
I beg a kind interruption here. Actually, we have had previous cocktail webinars also, and I'm fortunate to witness that and this. But this was, in complete nutshell, was ultimate, fetching 1,107 logins, 1107 logins. And it was quite mesmerizing and absolute Raja style of moderation. And everyone here, they did it brilliant. But the take-home message, what I already typed, which also Raja told, it's very important. We do not have much of the choice while treating the patients. You cannot send him empty-handed. You should always tell the patient that, yes, you can take this and this will work for you. But do not send the patient that nowadays, whatever is applicable today gets disqualified tomorrow. So whatever you do, whatever you give, even it's a vitamin pill also, that boosts the confidence, the morale. And the morale boosting is the actual treatment for COVID. So that itself does it. And fantastic, Satish sir, Ravi bhai, Vikas bhai, Keerat, and Viswesvaran. I could see that the door was repeatedly getting opened. I could also see a steel glass in Ravi Dosi's hand. I learned so many things from Ravi Dosi today. And Raja bhai, a fantastic moderation from you, absolutely, as always. And you try to learn something from Ravi Dosi also is my advice, that you can come out with a stainless steel glass and you will not be caught.
Fair point. So is that a signal to say
another 10-15 minutes
Krishna bhai for today, or shall we?
I'm leaving 10-15 minutes more. You can carry on.
10 minutes? Okay.
Yeah.
So we'll just take a couple of quick questions, and thank you, Krishna bhai, for being there. Highest regards. What was I going to ask? I was going to ask about, so doxy and ivermectin combination. We've got a proponent here who says that in this rainy season, this could actually be prophylaxis against leptospiral infection also, which I think is a valid comment. We don't have a lot of leptospira in India, in Kolkata, but I guess in places like Mumbai, it's a valid concern. There's a very senior colleague of ours, Dr. Mohan Rao from Orissa, who has said we've treated 12,000 patients, 12,000 Ravi bhai. So that probably even outnumbers you, of COVID in Bhubaneswar with doxy plus ivermectin, and we found good outcome, except for a few cases that needed the cocktail. So that's a very senior. I'm very thankful that Dr. Mohan Rao has actually listened to the entire webinar and put his comments in. So thank you very much, sir. There's a couple of questions which is about adalimumab. I'm sorry, it's a tongue twister. I can't pronounce that well, but I have no personal experience. I know the trial results. Anyone has prescribed adalimumab at all or not? You have, Ravi?
Yes, sir. I have used it in a good number of patients,
Okay.
more than 50. It is a
Okay.
drug which shows some benefits, sir. Again, needs more research.
Okay. And so what would your message be? I think that's the basic question. Is that something that we keep in our armamentarium going to the third wave, or do we say, like Satish said, not enough evidence, we'll keep it on the shelf for the time being and take it down if there's more evidence?
I would go with what Satish sir says, sir. We need more evidence.
Okay. And then there's a very difficult question from Gayatri Devi, Dr. Gayatri Devi in Andhra Pradesh. I wouldn't even dare answer this question, but if anyone on the panel would venture, different methods of doing the antibody titer, which method is the best? I have no clue, Gayatri Devi, but if anyone, I can see Keerat's hand. So the bright lady will answer the lady. Go on then, Keerat.
Neutralizing antibody test is supposedly the best method, and that is what is used for all research purposes.
So the labs that we have, Keerat, in the city, your city, my city, they all use the neutralizing antibody titers, or is it different tests like has been pointed out by Dr. Gayatri Devi?
So not all of them are doing neutralizing antibody assay. Some are using the regular estimate, that they have this another way of doing the estimates as well. But neutralizing antibody assays are a little more expensive. So, but
Okay. Thanks, Keerat, for that. I had no clue. So thank you very much for bailing me out. There's another very interesting question, Satish, and I'll put this to you. So convalescent plasma has been de-recognized, is the question. The mechanism seems to be similar to what is happening with the antibody cocktail. So why do we feel that the antibody cocktail works when the convalescent plasma doesn't?
Very good question. In fact, I think the cocktail antibody arose from the convalescent plasma kind of replication studies. So in fact, it is derived from there. The convalescent plasma, I feel, is polyvalent, which means it's not very specific, not directed towards the spike protein. So it was in general. So this is very specific, Raja, the cocktail antibody directed towards the spike protein and binds much more efficiently and prevents viral entry. That's why it's more effective than the polyvalent or the convalescent plasma. And then Ravi has a lot of experience using that, the convalescent plasma.
Yeah. So Satish, if sort of we put it in lay terms, what you're saying is similar to what we said about measuring the antibody titers. So for instance, when we are measuring the antibody titers, we are uncertain which antibody to actually measure. The convalescent plasma contains all sort of antibodies. Whereas when we're giving the antibody cocktail, we're having a specific antibody which goes and bites to the spike protein, which is why it works and the plasma doesn't. So thank you for that. Wonderful. There's an interesting question here. It says, does a patient need remdesivir if they are clinically stable after antibody cocktail, but the HRCT shows GGOs and consolidation? Let me answer that, Dr. Veeramani. The answer is a no. So never should we actually treat the CT scan. If the patient is stable, doing well post antibody cocktail, I wouldn't actually worry about what the CT shows, because all of us have seen CT scans undergoing a lot of change, a lot of improvement, a lot of resorption. Even traction bronchiectasis seems to have improved and vanished from CT scans after 3 months or so. So if the patient is stable, I would be happy. Keep a watch, but not give remdesivir to these patients is my message to you. There's another clinical scenario which comes from, again, Dr. Prateek, who's got, I have to applaud him because he's asked the most number of questions today. I have lost the question while I've looked for it. Let me ask a different question. Dr. Rahul Basse, a physician intensivist at Wokhard in Nashik, says, today I, along with my colleague, got admitted for COVID infection. I'm glad I picked this question. My other fellow doctors have also been detected to have COVID. We have attended small 2-hour CME on Saturday. I received cocktail antibody therapy plus first dose of remdesivir. It's my first day in the COVID ward. I'm interacting from the ward itself. Please guide me regarding time of recovery. C2 value is 14. Rest everything else is normal. the neutrophil lymphocyte ratio is 2.5. So first of all, Rahul, I have to congratulate you on being so keen that on day of admission to hospital on remdesivir, you're attending this webinar. So thank you for doing that. We are much obliged. We wish you a speedy recovery. So I'll give you my 2 penny worth, and if there's anyone else in the panel who wants to add in, person will add in. So I think the only indication for you to have the remdesivir was your high CT value. I don't think you've got enough symptoms to otherwise justify taking the remdesivir. You said your CT score is 14. There's a small trial which showed a CT score of 14 and above. You should be treated as severe COVID, which would include giving the remdesivir, but it's a small observational trial. I'm glad you took the remdesivir. I would have in your position. You've taken antibody cocktail, be in hospital. I don't think you need anything else other than supportive therapy for the time being. You might want to have the low molecular weight heparin in the meantime. If you do not have any hypoxia, you're very early in the disease course, please don't take the steroid. I think that's something that I would request you not to do. And keep a close watch for hypoxia, and hopefully you will be right as rain. That's my message for you. Guys in the panel, anything to add, anything to change? Yes, Satish.
Raja,
yes, Satish.
it's me. So I would advise this doctor actually to take the cocktail antibody straight away and not to take any other medication. He can just forget about it and then go home tomorrow.
No, Satish, this guy has actually taken the cocktail. He's also taken his first dose of remdesivir. He's done that already.
Yeah. So I mean, no need to take remdesivir. I feel no need, whatever may be the CT value or anything. Unless he is hypoxic, as you said, I don't think he should take any medication after a cocktail antibody. It works very well early in the disease, viral phase, 3rd day, 4th day, 5th day, and I'm sure he's also vaccinated. I don't think he should take any other medicine. That's my personal view.
Okay. There's agreed, Satish. I agree with you. My only point was this guy started on the remdesivir. He's got a high CT score. He's in hospital. He's a high-risk population. So maybe we can take an individual judgment. I guess they can complete 5 days of remdesivir and they then go home versus deciding, okay, I feel very well. Let me go home tomorrow. So I guess it's a balance, and you can sort of take an informed decision on an individual basis. There's another case, lots of case scenarios. There's Dr. Vinu from Kerala. So hi, Dr. Vinu. So your question, patient aged more than 65, day 3 with fever, 0 comorbidity, but a high CRP level. Would you give the patient the antibody treatment? So Vishwesh, you answered this question before. So I'll answer this question again.
What is the age, sir?
65. So 65, day 3, no comorbidities, high CRP.
I would still give, sir. He fits into the high risk criteria as per the age. So I would still give.
I would agree with you completely, Vishwesh. So I completely agree there. I would give it 2. So there's a question from Pratik again, who says resting tachycardia more than 100 without a dip of saturation in mild COVID. Should this be taken as alarming sign in high risk patients? So I'll answer that, Pratik, very quickly. We run out of time. Tachycardia, resting tachycardia is a poor prognostic factor in patients with COVID, right? And we know that a lot of patients who develop COVID myocarditis have resting tachycardia as being the only symptom. Having said that, is it alarming? Probably not, but you need to watch the heart rate. You need to make sure that this patient is not becoming continuously tachycardic. The saturations and the temperature needs to be watched, but I don't think this would mandate hospital admission if that's what you mean by alarming. And I wouldn't change my treatment based on resting tachycardia alone. I have lots and lots of other questions in the question box. We are actually flooded with questions here. There's one question from Dr. Rohinton in Maharashtra about unvaccinated pregnant ladies. So I think there's a definite guideline there. So Ravi, I'll take that to you. Unvaccinated pregnant lady, what would you do?
Well, cocktails have been shown to be safe in that group, although studies are still going on. Unvaccinated pregnant lady coming with mild COVID, I think we should definitely go in for a cocktail therapy because there is nothing to stop it. All the benefit we can offer her immediately.
Grand. So I think I'll stop there. We are 9:45, so 15 minutes over. I'm really, really pleased with the number of questions that we've had. I had a useful discussion, something that you can take home with you. Before we finish, let's ask for a one-line carry-home message for the third wave. So the question is, what do you want to tell the audience about preparing themselves going to the third wave in one line? And I'll start off with Vikas. Vikas, your message.
First of all, COVID is still not over. So we should follow the COVID appropriate behaviors, and still we should use masks, sanitization, and social distancing, because
Wonderful.
COVID is still not over. COVID can come anytime, so we should always be cautious.
Thanks, Vikas. That's a wonderful message. I'll take that next to Keerat. Keerat, your message about going into the third wave.
My message would be that as pulmonologists, our prescriptions are once they go into circulation is what becomes the trend. So we must prime the patients and start on offering them early antibody cocktail when we deal with patients.
Okay, grand. So that's your message, Keerat. Wonderful. Let me next come to Vishwesh. Vishwesh, your one-liner message for the audience, third wave.
So, antibody cocktail is the major revolution we had in the second wave, and I think we will carry forward with that. Third wave may or may not come, but I think following the COVID appropriate behavior is still the norm.
Sure. Thank you very much. So Ravi, your message going to the third wave.
Well, OPD-based treatments and treatments like antibody cocktail might not be covered by insurance. We don't know. But still, we should be very positive to using it, forgetting the cost factor and looking at the absolute benefit that it is going to give us. We should have a very positive frame of mind while using drugs like antibody cocktail.
Wonderful. Thanks, Ravi. Strong message there. Satish.
Yeah, Raja, very confident of third wave management. Whether it is there or not, because most of the trials are out and most of the drugs have been tested, and very confident, and cocktail antibody is a game changer.
Wonderful. Lots of positive messages about the antibody cocktail. I have a positive message about the antibody cocktail too, but to add to whatever else everyone said, there might not be a third wave if all of us get vaccinated and get vaccinated quickly. So please go and take your vaccine. We hope there's no third wave. We want to use the antibody cocktail if there is one, but we would prefer it if there was no third wave at all, and we still had to use the antibody cocktail in a select few. So thank you very much, all the esteemed panelists. So I had a lovely time. Keerat, Vishwesh, Vikas, Ravi, Satish, wonderful time. CCI prepares these platforms on a weekly basis and does these meetings, and a lot of effort goes into making these meetings successful. There's a lot of people. I will not be able to name everyone, but Krishna Bhai and Vijay Bhai, I think, need mention. Ravi here already. Keerat is the brain behind the journal that we're going to take out in a few days. And there's multiple others. There's Satish here, who is the wise man in CCI. There's lots of wise men. But thank you to everyone. Thank you to the audience who've been with us, asked all these questions today. I was delighted to be a part of this meeting, and all CCI meetings have been a part of. Thank you very much, and good night from our side.
Thank you.
Sir,
Thanks, sir.
important request to all viewers. We have only 5 days till 15th September. And as a mark of our gratitude for this platform, CCI platform, which has been brought forth by endless effort by Dr. N.H. Krishna, please nominate. These are the last few days. Please, the onus is on us. We must make that effort. It was only going to take 2 minutes. If there are any issues with the nomination process, please feel free to contact me or Dr. Atri anytime. Thank you very much. Thank you all panelists. Thank you, Dr. Raja. I'm very happy to be with you.
Thanks, Raja.
Thank you very much. Thanks, everyone.
Get well soon, Viswes.
Yeah, thank you, sir.
It will soon be.
Yeah, COVID came negative.
If you
happy note, and then it looks more like.
Are we offline now, or are we still online?